and expose providers and institutions to risk. That's why the faculty in the Center for Virtual Care have taken their extensive experience and crafted a comprehensive training program to help you and your team successfully in this new clinical arena. To date, we've trained over 500 learners. With that, I want to thank you for joining this webinar. You'll have an opportunity to hear from our faculty on how the pandemic has changed the virtual healthcare landscape, as well as to hear about some best practices for seamless virtual healthcare. With that, I'm going to hand it over to you, Chris.
Thank you very much for setting us up today, Dr. Sharma, and welcome viewers. I'm Chris Wofford at eCornell, and I hope you are all staying safe and remaining strong as you join us for today's hour-long keynote. A couple quick programming notes before we kick things off. The panel would love to take your questions throughout the discussion, so I encourage you to submit your questions for the doctors via the chat, which is in the upper right of your video stream window. You'll see a little chat dialog box there. Click that, open that, and you can submit questions throughout. I'll be feeded those questions, and I'll take them as they come as best I can. Note also that we are live, but this event is being recorded, so it will be viewable at this very same URL afterward. Just give us a couple minutes. The archived recording will be posted, and you can share it with friends and colleagues freely. Closed captions are also available at the Vimeo link, which is being shared in the chat right now. So I encourage you, for those who require or prefer closed captioning, check us out on the video stream itself. Today's panel of Frontline Virtualists are a team of doctors from Weill Cornell Medicine in New York City, who are also co-authors of eCornell's newly launched telemedicine course. So I encourage you to check it out at the URL also shared in the chat. Lots of action going on over there. But check out the telemedicine course via that URL that has just been shared. Several of our panelists here were authors of that very course. So let's get to it. Please join me, audience, in welcoming Dr. Christy Bush, Dr. Peter Greenwald, Dr. Neil Naik, Dr. Shari Platt, and Dr. Jiwan Kim from the Center for Virtual Care at Weill Cornell Medicine. We've got a lot to cover, so I think we're just going to get right into it. Dr. Christy Bush, let's open the discussion with you, please. So I'm going to ask you, what has changed the most since the pandemic in your virtual urgent care?
First, thanks, Chris, for having us. We are so excited to be here today. So I think for us, what's changed the most for our virtual care at Weill Cornell has been the demand by patients. At the height of our pandemic, our volume went from 30 patients we were seeing in a day to over 300. It happened overnight. Post our peak in New York City, our volume has been steady and continues to be higher than where we were a year ago before the pandemic. The other big change that I've noticed in our virtual urgent care has been the complexity of our cases. Patients are now requesting virtual urgent care visits for more critical concerns than they were before. For example, in the past, we were seeing a lot of simple urinary tract infections with patients, even something as simple as a medication refill. They were pretty common complaints. Now, we are getting patients, for example, with even acute appendicitis that we're seeing and evaluating virtually. And patients have been concerned due to COVID, and they're not running to the emergency department like they used to. And instead, they're scheduling these virtual urgent care visits for our guidance. So our providers need to be ready for anything, and that's what we've been delivering.
Dr. Jiwan Kim, I know you have a follow-up here. What has been your experience over the last year plus?
Yeah, thank you, Chris, for having us. So
yeah.
For pediatrics, it's a similar pattern, but we have seen that parents are much more reluctant to bring their children to the ER, and this is shown in low volume across all of the US. And so they're using telemedicine as a last resort to see if their child really needs emergent care, similar to adults. So telemedicine has been crucial during the pandemic because I think it helps families in both situations. So some are reassured that their child is okay to follow up with their primary pediatricians, but for some who actually require immediate care, we as pediatric emergency medicine doctors can recognize if a child is sick and give appropriate guidance on when they really need to be seen emergently. So during the height of the pandemic, we actually saw several patients who looked sick on telemedicine, and the families were still very reluctant to bring their child to the ED, and it took a lot of convincing. But once we saw them in the ED, they were so sick that they needed to be admitted to the intensive care unit right away. So it's scary to imagine what might have happened if we did not see them on telemedicine that night for these sick patients. I think another fact is that patients are realizing the convenience of telemedicine, and especially those with a lot of children and not adequate childcare options. So in the ER, we often have entire families accompanying one child, but this not only potentially exposes all the other children to COVID, but it's also a burden to the parent as they have to get all their kids ready, transport them into the ER. So when I tell parents about the option of telemedicine as a follow-up, they're delighted. So I think it's a great solution for low acuity problems, especially for these situations.
Yeah, patient care in late 2019, very different probably than it's looked certainly over the last year. So in what ways are patients responding or approaching virtual care? What kind of changes from a behavioral standpoint have you observed in patients? Dr. Bush, back to you.
So it's a great question. I think patients are definitely more accepting now. They're knowledgeable about digital health. Prior to the pandemic, many people never even considered a virtual appointment. Telemedicine was not familiar territory or a concept to so many. And there's an increase in technology awareness as well as the platforms where we're seeing patients on, the terminology, the tech terms, all of a sudden patients are aware. So it's exciting for us who have been practicing telemedicine for years. And there's also less fear by patients. They're willing to, try out getting on a platform, signing on, experimenting with the user faces, and they're more willing than ever before, which again, for us has been really exciting.
I want to just kind of back up to the technology point that you said there. I was just kind of checking pre-show notes. We have a lot of patients who have a lot of devices now that wear a lot of devices, Fitbits and et cetera, right? So you're able to kind of capitalize or use that data, which is kind of certainly a new frontier for you, right? I mean, people are kind of, well, I don't know how this works, but I mean, people are more willing to work with you in this kind of new and fresh and unique way where you're just awash in data, right? As far as it relates to patients. And I suppose that was an observation as much as a question, I suppose.
So I can tell you.
Can you get into that?
I'll start getting into this. And then I think one of the biggest things or devices, so to say, that we've been using since the pandemic has been the pulse ox. And patients are familiar with it now. Not only are they familiar, many have purchased them on their own because of COVID and the concern for their oxygen levels dropping. So this has been helpful for us, specifically this device, while monitoring patients who don't want to necessarily come to the emergency department. We can check to see, are their oxygen levels dropping? Is this a patient that needs to, we need to encourage them with our medical knowledge and expertise that they actually do need to go into the emergency department? Or is it the reverse, that they're actually doing okay and we can give them comfort by using this device and monitoring the oxygen levels and even having more frequent follow-ups so that we can track it? So for me personally, specifically the pulse ox device has been very useful in both extremes for patient reassurance, as well as those that are much sicker and critical and need to get to the emergency department for further care.
There's a lot of interest and excitement about these devices, but one of the things we really enjoyed doing this eCornell course was how much of plain old physical exam you can also do by telemedicine. Everybody's excited about the next new device that's going to let you do X, Y, and Z. But it's really surprising how much we can do that you do in person. The abdominal exam, for instance, you can do a very good version of an abdominal exam. And again, the eCornell course, it was a lot of fun to put that together in videos and make that more accessible.
Perfect. Thank you, Dr. Greenwald. Dr. Kim, did you have anything to kind of chime in as it relates to patients and how they're accepting and approaching virtual care?
Yeah, I think we've actually seen families becoming more creative and innovative and actually seeking and receiving care, especially with the HIPAA relaxation. So we've actually had parents being able to Zoom in for the urgent care visit while they're at work and their child is physically with the nanny or another caregiver or a teacher, so that everybody involved in the care of the child can actually be available for the visit without having to be in the same physical space or taking off work for the parents who are essential workers.
Thank you. Sorry, go ahead.
I'll just add one quick thing is that children also is to be able to examine them in the comfort of their own home is often even more effective than when they come into the ER where they're in a strange environment and they're so scared and they're clinging to their parents. But if you're actually able to watch them running around in their home, I had a child who was playing with his dog. His dad came home, he ran up to him, gave him a big hug. You can really get a much better physical exam and evaluation of somebody, especially for children, of their mental status when they're in a comfortable environment like their home.
Yeah, I agree. And going with the physical exam, I think partnering with a parent, it becomes really fun for the kids more than, being in an ER and the doctor approaching you to try to examine them, because we're just talking the parents through how to do a very thorough physical exam.
Perfect. I have so many questions rolling in. We have some notes to transition. So Peter Greenwald, I want to ask you from an administrative structural standpoint, what happens with the CARES Act, HIPAA relaxation, Medicare reimbursement? Where are we at with that? So I have a question from viewer Tapan Vakaria, who asked, what are the biggest HIPAA challenges over telemed visits versus inpatient visits? What are you dealing with?
Okay, that was a lot. So I'd say that the biggest thing over the last 15 months or so has been the lack of a stable state. Everything has changed in ways that are beneficial for telemedicine. The government made strong efforts in the states to make telemedicine more accessible by doing things like making a waiver of HIPAA enforcement to encourage people to get on any platform and do telemedicine, by making changes in the billing structure, and by removing some patient location limitations that allowed people to get paid for telemedicine visits. The question now is which of those changes are going to become constant and which of them are going to change again. Now, I'm a firm believer in patient privacy. So even during this waiver of HIPAA enforcement here at my shop, we've tried very hard to stay adherent to all the patient privacy requirements of HIPAA. And there are large technical hurdles there for sure, but I'd say the biggest one is just knowing who's in the room with you. When you can't turn your head and you only have a 20-degree field of view, it's really hard to maintain patient privacy to the point that we now recommend our providers start visits with some version of, am I having a conversation with just you, or are you and other people in the room with you?
Sure. Yeah, exactly. So let's talk about the practical. Let's move into the how-to. So let me ask you, Dr. Neil Nayak, what is the one thing that all practitioners can do, in your estimation, to improve their virtual health visits with patients? How does it play out?
I think there's a lot of things that we've had to learn practicing in this space, and I think the concept that Dr. Greenwald was just talking about of opening the visit with asking who's in the room kind of leads into what I think is probably the most important thing to understand about this space, and that is you have to let go a little bit. We don't have nearly as much control over the visit as we do in person. We take for granted how much control we actually have when we do an in-person visit. We have the ability to set up the room. We have the ability to have the lighting we want, the equipment we want in the room, an examination table that's laid out the way that we want. And patients have accepted this to the point where, we've all had the experience where we have a patient, or we as a patient change into a really flimsy gown in a cold room and are completely accepting of that, right? So we have all that control, and now we're giving it up. And the thing that we need to understand is by giving it up, we really need to partner with the patient. It's a 50-50 encounter. It's 50% the patient, 50% us, to set up that room, that virtual space, to have that encounter. And that includes knowing who's in the room on both sides of the visit, not just the patient side, but speaking to HIPAA, letting the patient know that we are by ourselves in this room as well, or if we are working with other providers that may be virtual as well.
Speaking of the 50-50 partnership, right? So presumably on your side, your tech is dialed, right? You're dealing with all the bandwidth you could conceivably need for something like this on the patient side. So what are some of the considerations that you have to think about when you're connecting with patients? So Dr. Greenwald.
We tell providers to test their internet connection. to make sure that they have adequate upload and download speed, but also an appropriate latency. And if you're not familiar with the latency term, that's the amount of time it takes information to get from me to you, back to me. And we've all been on those calls where everyone is stepping over each other because they think they were done speaking and they weren't. And that's usually a product of the latency being too high. And you can check all these things with just a Google speed test. There are several different platforms to check your connection. Yeah. And things like dedicated internet versus shared internet can also be a problem. And we often end up coaching patients through the various tricks we've learned to help stabilize connections. You know, if you're on 4G, switch to Wi-Fi. If you could set your device down and stop moving, sometimes that interrupts the connection. The list goes on.
Yeah. Well, on your side, you've got an IT infrastructure innovations team that also works to kind of improve this experience, this bandwidth maximization, and so on. Tell us a little bit about what's going on with that department in your workplace.
So let me just address the principle of that conversation first. Just like everyone else, a lot of physicians are now doing telemedicine from their home environment. Mm-hmm. So I think whether or not they have on the back end an IT team to help them when things arise, they have a lot of the same challenges that patients do in terms of stability of internet connection, in terms of the dog tripping over the power cord for the modem. You know, things like this happen to providers as well.
Yeah, I imagine so. This is one thing that kind of came up in our pre-game huddle conversation yesterday. So you're a university doctor doing virtual urgent care. And the question kind of comes up, and I've seen this happen a little bit in the chat here. Why are big institutions doing this? Why would universities not, see this kind of service to specialized companies and organizations and businesses that do it more cheaply, possibly in some cases more efficiently? At least that's their sales point, right? But I mean, what's in it for a big institution to take on this particular aspect of their infrastructure? How does this make sense?
So those of us in nonprofit medicine and academic medicine really feel motivated by providing the best care possible. And while Cornell, we've been involved in telemedicine not just over the last year of the pandemic, but for 5 years before that. And the reason we adopted telemedicine fairly early back in 2015 and actually clinical services in 2016 was not because we saw the pandemic coming, but because there was a thought that in order to provide good care, we had to be able to reach out and provide access in more ways than we were already. We talk about the advent of value-based care. I don't know how quickly that change is going to happen, certainly not as quickly as we thought back in 2016. But if we're going to change people's behavior, we need to provide them integrated care that reaches them where they are. And I have nothing against standalone commercial operators, and I understand that market efficiencies serve us well in a lot of ways. But care has to be integrated. In order to give good care today, you need to know about the care that happened yesterday, and you need to be able to arrange the care for tomorrow. And that's what's in, that's why academic centers, other nonprofit organizations are pursuing this as part of providing holistic care to patients.
You know, speaking of integration and kind of taking it in a slightly different direction, viewer Paul D has a question. Has the technology used to support telemedicine been integrated with current technologies that are used in your workspaces, that is EHR products, right? Or if not, how is this impacting care? So talk about a systems integration with whatever platforms you're using with telemedicine and how it kind of interfaces with some of the many other system components that you deal with every day. Anyone? No?
Maybe I've been talking a lot. Neil, I think you might have had an answer.
I was looking up at Neil, I'll tell you.
Yeah, so I think this is a really interesting question because it speaks to the progress that has been made in telemedicine over even the last couple of years. Mm-hmm. I think when we were, to be frank, telemedicine has been around for a while, in a lot of rural communities, things like that. But I think over the last 5-10 years, you've started seeing it grow in more urban settings as well. And during that time, a lot of it was piecemeal. And so there was a system for this, a system for that, and you had to figure out ways to make them speak to each other. And a lot of that were workarounds or repeating the same thing on multiple platforms. I think you're starting to see it get integrated, especially with EMR and things like that. As that gets better, I think you're going to start seeing the technology really start working for telemedicine a little bit better. You're going to start having integrated translators and the ability to connect to the pharmacist or the nurse or other professionals within the healthcare field to make that care seamless, right? If I get a call and I'm not a psychiatrist, but the complaint ends up being a psychiatric thing, can I connect them to a psychiatrist seamlessly? And as those systems start getting built out, as we're starting to become able to order tests at remote locations, remote imaging locations, I think you're going to see telemedicine care become more robust and grow as well.
Yeah, I'm certain that that's the direction it's going in. One gets the sense. So many audience questions coming in, but I want to keep us focused for right now on the telehealth training and how you kind of approach this. So tell us a little bit how that plays out from a practical standpoint and an operational standpoint, a management standpoint. Dr. Neal, back to you.
Yeah, the training aspect has been really interesting because I think pre-pandemic, when we were doing this, a lot of the training was forward thinking. We're going to be doing this. This is going to be integrated as part of our care, so we need to get providers ready to do this. And so our training started within the medical school. But as we started looking at it, as we started training, we started realizing, well, medical students aren't the only novices in this. We all were pretty much novices at this. And so we needed to not only train medical students, but train everyone, PAs, NPs, practicing physicians, nurses. They all need to be trained. And so we started developing training programs back then, one to teach how to do it, but what we realized is that the technology was going to change. So our focus ended up being less on the technical aspect, but more on how to do it in terms of how to communicate with your patients. How do you interact with them? How do you make them feel like they're getting care from a physician? How do you establish that patient-physician relationship? And so we did that through some online modules, but also integrating simulation within the education. Because it's one thing to just give knowledge to people and then have them just kind of file it away. It's another thing to actually have them experience doing it in a safe environment with a standardized patient and then discuss that. Similar to an athlete kind of watching videotapes of themselves shooting free throws or something like that and working on those skills. That's what we try to do at our Center for Virtual Care to really make sure when they're going into the clinical workplace and taking care of patients virtually, they know what they're doing and they feel comfortable doing that. Because if we're not comfortable on camera, our patient's not going to be comfortable with this care either.
And then we find ourselves using a term like webside manner, right? Which replaces the previous bedside manner. So how would you define webside manner? What does it look like when it's practiced properly or effectively? Christy Bush, let's kick it over to you.
Okay, great. I love this question because webside manner, I've had so many students say, okay, well, what do you mean? We know bedside manner, but what's webside manner? I actually love it. So for me personally, it's a combination of your self-presentation while delivering high quality care. You're exhibiting professionalism and empathy, all while trying to kind of melt that computer or phone screen away. For essentially there to feel, and for the patient to feel, is that there's no barrier. And all that combined to me is my personal definition of webside manner. It's still the art of medicine that we know and that we love. It's just in a different space. And there's a skill set for this, and there are tools to learn to deliver effective care in this space. And that's what we've been teaching at the Center for Virtual Care, which has been so exciting and such a privilege to do.
Hey, Chris, if I could add a couple of comments. One thing that we do want to emphasize is that doing a telemedicine visit is not just FaceTiming your patient. it's a lot more than FaceTime. Now we're so used to the virtual medium, we basically get on a video, but you have to be properly trained in terms of doing that visit. What I like to say is you would never expect a medical student to go interview a patient, do a history and physical exam, until you actually gave them, that medical student, the skill set on history taking and physical exam taking. Why is it any different with telemedicine visits? As I said during my introduction, it literally only takes a few seconds for a telemedicine visit to go poorly. It could be a few split seconds where the visit doesn't go well, and that ruins entire physician-patient experience. So, it's not just about FaceTime. It's really a core skill set that all of us as future healthcare providers have to master.
One of my colleagues last week went on a virtual visit with his mom to a world-class institution, not my institution. Met her physician wearing a baseball cap, wearing a t-shirt in his bedroom. And his response was, "Who is this guy?" And that's the polar opposite of what Dr. Sharma is talking about. We want that professionalism, courtesy, respect that creates a therapeutic environment for patients.
And I think, during the pandemic, our patients may be a little bit more forgiving because we're all in this situation. But I think as we move further away from the pandemic, they're going to be less forgiving of that kind of behavior. And right now, a cat filter that pops up on a Zoom call ends up being funny and ends up being a viral meme, right? But in our setting, if that happens, right, that's unprofessional, and it could destroy that patient-physician relationship. Remember, they're calling us at their most vulnerable points in their day, and so something like that isn't as funny. And the thing is that HIPAA protects the patients; it doesn't protect us. And in many states, the patient doesn't even need to ask our permission to record these encounters. So we need to make sure that we're putting our best face forward and acting professional when we're conducting ourselves in a professional manner.
Yeah, I heard all that. I don't want to get too sidetracked here, but I do have a thought-provoking question from a viewer. This is Tapan Bakaria, MD again. How can you assure the accuracy of diagnosis over video versus inpatient visits? How does this kind of play out when you get into the educational component of teaching this and instructing on telehealth? Dr. Greenwald. Oh, I think you're on mute.
We could do a study of going off mute.
Yeah.
I think a lot of the work has yet to be done, but in one of my hats, I do quality assurance on our telemedicine programs. And I can tell you when I compare virtual abdominal exams to abdominal exams that are subsequently done in person because a patient was referred into the emergency department, those exams end up being very similar. To the point that we've correctly identified appendicitis multiple times on virtual visits. There is some literature to suggest that examinations in the throat might not be quite as good as the physicians thought they were. So I think this is a whole rich area of future study where we're going to learn what we can do well and what should be directed for a face-to-face encounter.
And it sounds, go ahead, Dr. Knight.
I think until we have that data, though, the thing that we kind of teach is to take all this information and interpret it. You're asking your patient to help you through parts of the exam, and some patients may be able to do it a little bit better than others, right? If you have a family member on the other side who's medically trained in some capacity, you may trust the information you're getting a little bit more than someone who isn't. But taking that information into your medical decision-making, weighing it properly, seeing whether things agree or disagree, and then making your medical decision based on that is part of what we have to do. And so looking at all this information as data points with different weights based on how credible we believe it is may be the way to approach it until we have more data to integrate into our decision making.
There's some elements of this environment that will be superior to an office visit, right? Mm-hmm. I see into a patient's home. I get a better sense of what their support structure looks like. At the same time, I might not be able to see inside a patient's ear unless we have a specialized device for that. Mm-hmm. So like care in the office is different from care in the emergency department, is different from care in the pre-op suite. Care by telemedicine, it's a different environment with its own strengths and weaknesses.
Right, and that's been the story of the pandemic kind of throughout, right? I mean, everyone in almost every business has found certain efficiencies and smarter ways of doing business and delivering medicine, and that seems to be the case here as much as anywhere else. Dr. Kim, did you have something?
Yeah, and in pediatrics, they've actually been studies showing that for like things like respiratory exam and skin exams, that there's very good accuracy in terms of doing telemedicine visit versus in-person visit. So I think that's an important point, and I think this is where the education for telemedicine really comes in, because I think providers need to discover and understand like the new skills that they didn't even know that they needed. I've heard of so many providers saying that they've just been thrown into telemedicine visits and that they can't do a thorough physical exam. But I think with a formal telemedicine training, you learn what you can do. And like we mentioned before, like doing a methodical physical exam by partnering either with the parent or the patient is such an important part. Mm-hmm. And I think as we do more and more visits, we learn to sort of MacGyver things. So even for throat exams, we've had patients taking the back of a fork, pushing it down with a separate phone into their mouth. And like, I've been able to get really good views doing things like that. And I think these are things that we learned through experience throughout our last couple of years that I think would be important to educate people about.
Please don't put a fork down your throat in a non-medically supervised environment.
You got it. So speaking of telemedicine training, for those of you who have missed the first segment of today's show, these are authors, co-authors, and faculty authors for eCornell's new telemedicine course, which I think we should share the URL again in the chat. We've heard this course referenced throughout, so I just thought to answer those questions that might come up, what is the course they're talking about? There you go. Check it out. It's at ecornell.com. So let's start looking to the future, right? So we've seen the demand for telemedicine training. There's certainly an eagerness among residents and students and everybody to really get on board. The tech is advancing quickly. There's so much happening with it. So let's look into the future. It's, in the pandemic, it's been hard to think about 2 weeks from now. However, we do have a good idea of where things are going. So Dr. Sherry Platt, I'll ask you, what are your hopes for the future of digital health? Where do you see things going? What's encouraging to you? Challenges to overcome? Where are things from where you sit?
Thank you, Chris. I think when it comes to looking into the future, one of our biggest barriers and challenges that the pandemic has highlighted is disparities in telehealth care for underserved communities. So that is where I think that in addition to the training focus, I think that outreach and education for underserved communities is really needs to be a priority. So a few of my colleagues and I conducted a study looking at this during the height of the pandemic, and I think, do you have the geocode slide?
Yes, that will be displayed there. So tell us what we're looking at.
There's a map that I think the viewers can see, and what this is a geocode map of zip codes. On the left is the zip code for NYP virtual urgent care during April 2020 at the height of our pandemic, and you can see by zip code the use of our virtual urgent care program. And then on the right are the zip codes where the highest rates of COVID disease was. And as you could see, hopefully, you can see that the areas where the highest rate of COVID, where you would think they really need high use of telehealth, was actually some of the lowest use of telehealth. So we have established 4 action plans to try to improve the access to telehealth services for these underserved populations. The most important is language. We're getting a lot better. The telehealth programs right now are offered in multiple languages, but there are still aspects of accessing the platform that you need to have English fluency. So we have still ways to go when it comes to language. The second thing is a barrier is technology, and particularly in rural communities, and I know this is a broad audience, so it might impact this audience, there are broadband connectivity and internet connectivity issues in rural communities. In New York City, we have less connectivity issues, but in fact, in our lowest income population, many people, in fact, do not even have data services or subscriptions. So we still have a ways to go for that, and that's going to be an important focus. Cost has always been a problem, but in response to the pandemic, before the pandemic, telehealth services many telehealth services required upfront payment, so that became a barrier. But luckily, in response to the pandemic, Congress passed the Accessible, Affordable Internet Act for All Act. And what that did was it improved internet accessibility for low-income families and also digital literacy, which I think is really significantly improved that for these communities. And then the last but really important piece of it is marketing, getting the word out, because for many, many reasons, there's still a mistrust in these lower income communities and underserved communities. And so they will tend not to use these digital platforms for their medical care. And we really need to do a lot of focus on educational outreach and reach out to the communities that really so much need it, especially these communities where COVID is so prevalent, to offer them more education around accessing virtual urgent care. And also another way to do that is to reach out to community leadership so that they can get buy-in from their leaders and and they could promote virtual urgent care in their communities. So I think for the future, really addressing disparities in telehealth care is a goal. I think we are doing so much better than we were before the pandemic, but we still have a lot of work to do.
Viewer Paul D asks, this is a good question, has virtual emergent care been made available to rural underserved populations either directly or indirectly through other healthcare organizations? What are other ways with dealing with the technological disparity and the simple access kind of things? Is there anyone else playing part in this, in helping kind of right some of these wrongs and fix some of these gaps?
I mean, in the rural communities, I don't have as much familiarity, but there is a lot of research done in this area. And I think there has been a lot of improvement. There's been a lot of focus both on a national level and a regional level. And understanding that internet connectivity is the first step in getting these patients who are sort of really, in fact, it's even harder for them to reach in-person medical care because travel is difficulty and weather might be a barrier. So having more efficient internet access in the rural communities definitely has been a focus and is very well recognized.
I'd say it's not just the internet connection, but it's the devices, right? In an analogy, I wouldn't expect a patient coming into the hospital to bring their own bed with them, right? So we may want to find ways to deliver technology to patients when they need it. Involved in a couple programs through Weill Cornell that do that bring the tech to the patient's bedside. And those programs are a lot of fun and might point some of the way forward for the things Dr. Platt's talking about.
Dr. Greenwald, what other challenges do you see facing telehealth in both the near and long-term future?
Well, there are studies that show provider practices adoption of telehealth is inversely proportionate to the size of the practice, which makes sense. If you have a 4 or 5 provider practice and you're trying hard during this pandemic times where people are seeing the doctor less often to keep the lights on, the prospect of embarking on telemedicine services when the regulatory environment is unclear going forward, I understand those concerns. Why spend time and energy that you don't have to begin with to develop new systems when the regulatory scaffolding on which those systems are built might completely change in another 6 months?
Mm-hmm. How about, sorry, go ahead, Dr. Sharma.
So, my comment would be that, I think as telemedicine has really grown exponentially, especially in the last year, I think healthcare systems are going to be forced to show that we are able to provide high quality, cost effective care. All right, because that I think is the big question. So while we have expanded telemedicine services, is the cost, is it worth it? And also, are we providing high quality care? What are the outcomes? What are the quality standards that we're using? Here at New York Presbyterian and Weill Cornell, we actually are coming up with quality standards that we're defining for all our telemedicine services. And I think we have to show that this is an impactful way of providing healthcare. That's cost effective, and also we're able to provide value-based care. Because if we can't show that, telemedicine is great, but it might not be the end-all, be-all solution to providing healthcare.
What about challenges that you face with stability with payment for telemedicine services? We have one of our viewers here chimed in with something kind of thought-provoking. Aditi asks, considering that emergency departments often see patients without insurance, is virtual urgent care still accessible to those types of patients? How does that all play out in this environment? That's a jump ball. That can go to anybody.
I think that has to do with the willpower of the institution. You know, the regulation that makes emergency care available to all, regardless of ability to pay, that exists because of statute, because we've decided to do that as a society.
Yeah.
The equivalent doesn't exist for telemedicine, and perhaps it should.
Mm-hmm.
But here at Weill Cornell, we will see you regardless of whether or not your payment information checks out ahead of time. Unfortunately, we'll also bill you on the back end, but I'm not sure that's all that different than emergency department care. But we're not forced to do it. And maybe there's a future where society takes that on.
Yeah,
I would add, though, that there have been a lot of changes around Medicaid reimbursement and flexible reimbursement programs for underserved communities, and I do think that I don't know if that's going to last in a world after COVID, but I don't think COVID's going away very quickly, and right now there have been a lot of ability to pay and support from our government for patients to get access to telehealth services specifically.
I have an operational payment type of question from viewer Rajan Lai, who asks, as insurance reimbursement rates are determined by the states, how do you handle a situation when a patient is out of state? I know we're kind of getting in the weeds of this, but how does this play out? Anyone know? State-to-state reimbursements? Yeah.
Yeah, the whole providing care across state lines is very complicated and has a ton of detail behind it. Some of the emergency provisions having to do with COVID have made it possible to see patients across state lines when it wasn't possible before. Mm-hmm. Some states have managed that in a more detail-oriented way than others. Mm-hmm. Some states already before COVID had reciprocity agreements across state lines, but not too many. The first step in order to be able to bill a visit is, can you legally provide that care? I'd say trying to sort this out as a sole provider is a very daunting task. I'd say you want to be very careful that you are billing appropriately and providing care within a legally sanctioned framework, and you want to do that with whoever you turn to for legal advice.
Mm-hmm. Very good. So, Dr. Nayak.
Yeah, I think this is a great question, because I think these are some of the questions that we've been getting from a lot of our learners who have taken our courses. Because there is the educational aspect of teaching how to provide care, but then there's also we need to teach some of these regulatory frameworks that exist, at least what's current right now, and understanding those things. Even simply the idea that the visit happens where the patient is located. So even if I may be in New York and I may have a license in New York, if my patient is across the river in New Jersey, right, I may not be able to take care of them and have to end the visit before providing medical care. That concept is tough for providers to fully grasp, but it's even harder for the patient. And so being able to understand that and explain that in a succinct manner is something that we need to teach providers as well. and something that needs to be part of the educational endeavors that we partake in with regard to telemedicine.
Just to give you a sense of the nuance, taking Dr. Nayak's example, if I don't have a license in New Jersey, I can see the patient I saw in New York when they're in New Jersey later today, provided I saw them in New York. But if I never saw them before, I can't see them in New Jersey.
Mm-hmm. Boy, oh boy. We have a viewer question that's kind of related to what we're speaking about here. Does anyone feel that the regulatory environment around telemedicine and video medicine in 6 months or a year may be supportive or kind of generally unsupportive to the practice? And this will get us to our prognostications and looks to the future in just a minute. But how do you see regulations, the regulatory environment? Which way is the wind blowing there?
Chris, I can take that. So I do think, telemedicine is here to stay. So I don't think we're going to be moving backwards in terms of making it more difficult to provide care. I do think the thing that we have to understand is, the magic wand that happened during COVID, where everyone was allowed to provide care. It's going to be a negotiation, and there's going to have to be a middle ground where states are still allowed to have control over who they're allowing to practice medicine. I think you're going to have more participation in more states regarding, licensure, what states participate in that. So, I would say that I think it is going to get better, but at the same time, we also have to protect, our patients to make sure that the people that are providing the care are qualified, are trained appropriately, and we're not just letting anyone practice telemedicine. So that's those are my thoughts on what the future holds.
Speaking of the future, for those that may not be on board with your prediction that telemedicine is here to stay, right? So let's say there's a skeptic who says, well, we're going to be back to in-person, everybody's going to be vaccinated, we're going to get through this. What do you say to that person? Obviously, we've just described so many practices and ways of doing delivering medicine that have improved, but what do you say to the skeptic who says,
the analogy I like to use is 5-7 years ago, you would have probably never bought a shirt on the internet, and you would probably never bought vegetables, right, online. Okay, but we got comfortable with doing that. And when it comes to healthcare, I think as we get more and more comfortable with providing care, to seeing patients, and to do it in a safe manner, people are going to be more accepting. People aren't going to want to give up 6 hours of the day to have a minor checkup with their doctor where it's going to require them to travel and wait in a waiting room. There's some people that are still going to want to do it. So I don't think that we're going to go backwards. There's still going to be some naysayers, but I'll tell you, 5 to 7 years ago, I didn't believe in telemedicine. I thought we went to medical school to put our hands on patients, to examine them, to listen to their lungs and everything like that. How could we do that via telemedicine? And now I'm convinced, because I'm convinced that in the right setting, Chris, and I want to make sure we emphasize, in the right setting, this is a great way to provide medicine. Telemedicine it's medicine. It's just providing medicine via a different platform.
I want to actually pose this question to the entire panel. So let's go in sequence. Dr. Christy Bush, what do you think about the skeptics that might dismiss a lot of what we've discussed here as developing best practices?
So, Dr. Sharma kind of said it perfectly, but I think for the skeptic, I'd say, why are you skeptic? Is it because you're just not comfortable with change? Maybe that's the reason. And to get somebody more comfortable means maybe they're going to need more training, get them comfortable. And, if they've been practicing for years prior to the pandemic, no matter how many years they've been practicing, there's always room to grow and learn. So seek training from those providers who have been practicing telehealth for years, and let's continue to learn and grow from each other and expand with the art of medicine and all the unique tools that we still now have.
And you all are learning that patients, when delivered properly, are on board, right? I mean, you're getting generally positive feedback. I see a lot of nods here. That's what you're experiencing. Maybe we didn't emphasize that enough in previous conversation today, but patients are into it, right? We're getting results.
Yeah, yes, for sure. There is a demand, there is a want, and there is a need by patients. They have now recognized the convenience, how they can have much more frequent checkups versus seeing their doctor once a year or once every 6 months. So there's a convenience, there's an ease to it. So it's here to stay for sure. It may not completely take away from our in-person encounters. It's just going to supplement, and it's a nice addition to have.
Dr. Kim, what do you say to the skeptic?
I would say it's sort of the same thing. It cannot replace in-person visits, but it's something to supplement. And I don't think that telemedicine is ever going away. Like Dr. Sharma said, people are already realizing more and more that telemedicine, and in the future, especially with good education of providers, is a efficient and effective mode of medical delivery. And from a pediatrician's perspective, I think the best thing is that we've mentioned this before, kids can be evaluated in the comfort of their own home for minor conditions. And we as providers are actually better able to evaluate the children when they're comfortable with their own family, in their own home, with their toys, and they're not frightened like they're often in the ED. So I think especially as peripheral devices such as otoscopes and stethoscopes that connect to phones become even more widely accepted and available, I think telemedicine will become even more desired by patients and providers.
And as accessibility and equity increases, Dr. Platt, where do you see things going? And what do you say to the skeptic who might be not fully on board at this point? You're on mute.
Sorry, I agree with what everyone has already said.
Yeah.
I think that the skepticism will eventually go away as not only we started virtual urgent care more than 5 years ago, but now because of COVID, their pediatricians are being seen on telemedicine, psychiatrists are seeing patients on telemedicine almost exclusively. And so internal medicine, everybody. And I think that patients are getting used to it. You know, school is now virtual. Everyone's doing work on Zoom. So I do think that there is going to be more and more buy-in for telehealth services and more demand. And I think that what we need to do on our end is, I agree with the focus on training, because I do think that now that everyone's doing it, they just think it's super easy. But in fact, I think there's really a lot of skill involved, and it makes a difference to be well trained in the ability to give good care and have the patient feel that they've had a good experience. But I also think that it's going to be more and more accepted. So we need to make these platforms be easy to access. We need to make it be a very, very seamless, like I'm on my phone, I click a button and I'm there. And so it may be a little less logging in, putting in information. There's still sort of emotional barriers to doing this, especially for people who might not be fluent in English, but also the elderly or people with a lot of kids running around. So there are still, it's still a little daunting, but I do think that it's going to get more and more easy.
You know, when the pandemic first hit, online education was one of these things that kind of took a hit because we saw so many people doing it improperly, right? And so when done well, it's highly effective, and we know that we're in that business. So for me, it was disheartening to see how much people struggled with just simply the concept of educating children online. But here we are, Dr. Neil Nayak. How do you see things going forward? How do we address skepticism? People who are not fully bought in. What's your take?
So I think, you know, my response to that is I think the skeptic is being narrow-minded about how they're thinking about telemedicine. Mm-hmm. And I think we're going to see this as we go forward. I think up until now, we've been looking at telemedicine a little bit as not necessarily a replacement for in-person care, but something that is similar to in-person care. And I think as we go forward, we're going to start thinking about telemedicine as something completely differently, something completely different that we can start maximizing and unlocking potential. You think about, you know, a sleepaway camp where now the doctor on site is a telemedicine doctor who can, you know, make a decision whether or not they need to be brought to the hospital that's in the city versus can get care right where they're at, and they don't have to leave the camp. You look at the ability to really connect with people in their own homes and utilize what they are doing at home to really help take care of them. And you start thinking about hospice patients and the ability to keep them at home and take care of them in that environment that is more comfortable to them. Or patients with dementia who are, again, more comfortable in that environment, and bringing them into the hospital may actually exacerbate things. So I think, to the skeptic, my response is you need to broaden your horizons a little bit and look at it from a different angle, because I think telemedicine is going to grow into areas where we never thought we could provide care before.
Dr. Peter Greenwald, I want you to answer that, but I also want to bring in, if you allow me, I want to fold in a viewer question, which I think is really thought-provoking and a great way to end the hour, because I know we're coming up against the end of the hour here. Nana asks, will there be a point in the future that a Zoom visit will be able to detect a lymph node too firm, a spleen or liver too large, or an unexpected prostate nodule with a normal PSA? So do we have, I mean, there must be little moves toward advancing the equipment that we put on the patient side in order to provide this kind of diagnosis. What do you see in the future?
Well, so there are two ways I could address that question. One is to start talking about haptic feedback and other kind of sci-fi sort of stuff, but that's not the direction I want to take it.
Okay.
I think the nature of that question is, can you honestly stand there and say telemedicine is going to do everything an in-person visit does? I think that's the nature of the question. And the answer is 100% not.
Right.
Now, this is a additional type of care that will be better suited for some things and less well suited for others.
Right.
What I would say to the skeptics is examine your own skepticism. Are you really skeptical, or do you just A, not want to change, or B, does it bother you that the patient can just click a button and disappear from you because they're in more control now, and it's the loss of control that bothers you?
Yeah, right. Exactly. Any final comments? Dr. Sharma, you want to send us out here? I'll just say one more time that these are the co-authors and faculty that authored eCornell's new telemedicine course. We're going to share that in the URL, share that URL in the chat. But Dr. Sharma, take us out.
Well, first of all, I want to thank you, Chris, and eCornell for partnering with us to offer this webinar. And I want to thank everyone who's attending this webinar. What I would say is, especially for the naysayers and some of the skeptics, give it a chance. Telemedicine is really a great way to give excellent medical care if it's done in the right setting with the people that are fully trained to do it appropriately. We look forward to sharing our experiences, and we would love to hear from everybody else. But this is the future of healthcare, and we have a very, very promising future in terms of the way we could provide high quality, efficient healthcare via this medium. So I just want to thank everyone for attending this webinar and wish everyone well, especially during this ongoing pandemic.
Dr. Sharma, Dr. Znayak, Dr. Kim, Dr. Bush, Dr. Greenwald, and Dr. Platt, thank you all so much for joining us. Thank you, audience, for joining us with the excellent questions. We look forward to connecting with you in the future for future programming associated with Weill Cornell College of Medicine. So thank you very much, everyone. Stay strong, stay healthy, and stay safe. See you next time. Thank you.
Thank you.